Good morning. Yeah, I know. Now this is a great way to be in the room over there, really. So, good morning. I was actually scrambling to make a quick slide before. This is really meant to be a conversation, and on a topic that's hopefully quite timely and one that I think, depending on your perspective, you probably hear a lot about, right? And the notion of how do we think about transparency in the context of empowering patients and the convenience. And I think one of the things that we'll try to do today is to kind of give a dimension you don't hear a lot about, which is kind of what's the strategy underneath it, particularly if you are a provider. And I'm John Adractas. I'm pleased to be here. It's my second year with MedX. So it's one of my favorite conferences of all the different conferences that maybe you go to. I find this to be one of the ones that's a lot about change and hope, as opposed to just sort of learning about. Sometimes you can almost come away a little depressed about the given topic. But I think most importantly today is the three people sitting to my left. And it's meant to be ability for us to kind of zoom in from different levels. We've got Dave Johnson to my immediate left, who previously in the world of banking from the healthcare perspective, an author and an analyst, recently wrote a book that I'm sure he'd be happy to talk to you about, which relates to healthcare consumerism. Give us that kind of macro perspective. To my left in the middle, we have Dennis Roemer, who comes as a healthcare provider from the leadership perspective, a CFO, and talk about what's the challenges and what's the perspective there. And then thinking about it from yet the front lines of innovation, and Ellen Zwickl, who's at Consul and has been thinking about how their business kind of really as a supplier in this world of something innovative and how that comes, touches this topic and how ultimately does this work. So with that in mind, Dave, why don't you kick us off and kind of think about why are we talking about this? And I'll just pass it down to you. Why are we talking about this as a topic, and how do you see it?
Right. Well, I don't know how many of you were in for the previous presentation on spirituality, but we're going to move very much from the sacred to the profane here. John's asked me to sort of talk about the health system from a macro perspective, and I thought I'd do it first by asking you each 3 yes or no questions. So just raise your hand, a little audience participation. So the U.S. spends about 18% of its economy on healthcare. The next big country with the next biggest percentage is France at 12%. How many think we need to spend more than 18% to provide adequate or even superior healthcare services to everybody in the country? Who thinks we need to spend more than 18%? Anybody? Okay. We spend about 80 to 85% of our healthcare dollars on chronic disease. How many think we're winning the war against chronic disease? Nobody. Okay. So based on
so much for my optimism case.
Well, yeah. Well, no, I'm going to get there. But based on those questions, and I've asked them to huge audiences over the last couple of years and never had anybody raise their hand on either of those two. But my guess is you might feel differently on this third one. So based on your previous two answers, how many think we need to shift resources out of acute and specialty care into primary care, health promotion, chronic disease management, and behavioral health? Everybody? Okay. So that took probably about 45 seconds. So it's not really a question of what to do, it's how we're going to do it. There's more than enough money in the system. It's a distribution question, not a funding question. We're not attacking our biggest problem, and we need fairly major structural reform. So how's that going to happen? But maybe before that, and John asked me specifically, he heard a speech I gave recently, and asked me specifically to mention a chart that I had in that speech. And it came from a health affairs article that showed Mass General Hospital, one of the great hospitals in the country, their mortality rate against their average cost per discharge since 1800. So mortality starts off very high, costs start off very low, mortality comes way down, and actually costs dribble around until 1965, and then they're like a hockey stick going upward. What happened in 1965? Come on, I know you're young, but you should know this. Yeah, Medicare got created. So there are two original sins in Medicare, back to the beginning, that influence what we have today. The first is Medicare paid for activity, not for outcomes. And the second was they put into law no governmental interference in medical decision making. Therefore, anything a doctor prescribes and can justify, which is an incredibly wide standard, the government has to pay for. So is it really a surprise if we pay people for doing things that they do more of those things? We actually have what economists call supply-driven demand. The biggest predictor of cardiology procedures in a given market isn't demographic factors, it isn't lifestyle factors, it's how many cardiologists are in that market. Honestly, it is. I heard some people laughing. And the results are kind of this bloated, inefficient health system that overemphasizes acute care and underemphasizes logical preventive and maintenance care. And John said I spent last couple of years writing this book, and I got to feel like what I was really writing about was the equivalent of Star Wars. You know, on the one side, you got this medical empire. I mean, huge hospital systems, huge insurance companies, huge device manufacturers, huge pharmaceutical companies, living pretty well right now. I mean, Mylan was just in the news for EpiPen. It's great when you can raise your product 550% over 7 years with no improvement and take money home to the bank. So they've got a pretty good. They're fighting with everything they got to keep the status quo intact. And on the other side are us, society, and what do we want? Better health care, more affordable health care, more convenient health care, more compassionate health care. And the two sides confront one another in the marketplace, and the heroes of the story are those young and old, companies young and old, new and small, that are really trying to deliver on the promise of better health care at lower prices. And they're small, and they're energetic, a little disorganized, but they got Luke Skywalker and Yoda and the Force on their side. And America is a consumer-oriented society. So my whole point in the book, Market versus Medicine, is that the solutions aren't going to come from the government. They're going to come bottom up in an organic, evolutionary way, and they're going to win, and the winners are going to emerge by delivering real value to customers. And ultimately, those that really win will be those that get truly on the side of patients. And we can delve more into that if you want, but that's my macro view of what's going on right now. Oh, and just one other point, and the reason a conference like this is so important, the amount of venture money and private equity money, I used to be an investment banker, flowing in not only into healthcare services, but into provider-based services, ought to scare every single hospital administrator in the country right now.
Thank you, David. I guess this turns you into Darth Vader a bit, the representative of the
provider space.
I felt him nodding.
So I am definitely evil. Okay. So the audience participation part, I want to go back to that. How many in this room feel that hospital prices are too high? Okay. That's what I do for a living. But I just want to give you a CFO's perspective on this from two angles. Number one, no CFO in the land is going to claim that their prices are too high on average. Okay? They're going to say, well, in our ecosystem, our prices are set through a variety of mechanisms and negotiations to yield an operating margin of 2, 3, 4%. And I don't think anyone would argue with, okay, a 3 or 4% margin seems fair. It's a little higher than a grocery store, a little bit lower than Comcast or your favorite utility provider, whoever that may be. But it's enough to...
Nobody likes Comcast.
I call them communist. I'm sorry. I know this is recorded, so some risk. But no one would argue that that kind of a margin is unreasonable. The problem is our pricing is based on a cost structure that's inefficient, that is driven by a lot of duplication, a lot of redundancies, a lot of inefficiencies in care processes and things like that. And we know that. And we know that we have to deal with it long term. But no one would, as a CFO, argue that our prices in relationship to that cost structure are unreasonable. It's just that the underlying cost structure is pretty bad. Now, how many of you have heard of the person Joe the plumber? Okay, you all know who that is. Okay, well, I, on the plane ride here from the East Coast, got to sit next to Ralph, the cabinet maker. I don't really know what his name was, but for 45 minutes, he asked me what I was doing and why I was coming out to San Francisco. And after the conclusion of our 45-minute conversation on healthcare, I said, I've just taped what we talked about, and I'll just play it back for this panel I'm doing. But 3 sentences that he used resonated with me, and I want to use them here just to describe, in those 3 short sentences, plucked out from all of his comments, how we feel as chief financial officers. One was, this costs what? How much? The second thought was, I thought you were nonprofit. And the third sentence was, wow, look at that big new building. So you put those 3 thoughts together, and what is he really saying to me? Right? You guys make more money, you spend it unwisely, you know, et cetera, and we end up paying a lot of the cost for this. So in my mind, there's probably 3 reasons why we don't have, you know, costs are high, we need more attention to price. Prices need to be more transparent, they need to be more published. We also need more data on quality, which we're getting better at that. But I think there's 3 reasons why we don't get more of that information. I think they're more attitudinal than ability or capability. Number 1, believe it or not, I don't believe that we put enough pressure on all of us as patients, as employees, in the sharing of the dollar of cost for healthcare. So I don't think we're still adamant enough about getting price information. I don't think we are pushing for the information as much as intellectually we're there, but when it comes to the point of care, I sat next to someone on the bus this morning getting here, and I asked her some questions. She really didn't push for the pricing information. She got it from an insurance company that called her, but she didn't say, I want to know your price. So we, the ones that are sharing more and more of the cost of health care through high deductible health plans and whatnot, still aren't pushed enough to the brink. Secondly, employers, interestingly, are not pressing for data tables on prices and so forth. Dave and I were talking about this yesterday. Employers are still thinking about healthcare benefit, you know, through the HR function, not through the economic or maybe finance engine of the organization. Afraid to take away a benefit, afraid to lean more on employees for the cost of care. Also, there's contract law, public policy, a lot of regulations that preclude us from being able to push out this kind of information. And thirdly, I think it's somewhat on us. As providers, we're reticent, hesitant to promote and display the pricing information because there's some information, some prices that don't make sense. While on average, they come out to a 3% margin, you can look at the cost or price of a lab test or a pill or whatever, and you get the remark, this costs what? How much? So we have some barriers, but I'll come back in my next round of points when we get into strategy and talk about how we can deal with some of those things.
Thank you, Dennis. And Ellen, I think it's remarkable as you get into, you're in some ways kind of yet connected from upstream and patients having choices, a little less so than maybe the acute non-elective care.
Yeah, so a little background, I work at Counsel, which is a laboratory, so we're a little bit in a different part of the industry where we work with providers, but we do not have a direct relationship with the patient. However, our clients are providers who order our test, and our customers are our consumers are the patient. So our consumer and our client are not actually the same person, and both of those different groups actually require very different products to help them understand pricing or to help us kind of get them to order our testing. So I also work we're genomics testing, which is a fairly new industry in the marketplace. Insurance hasn't really figured it out yet. There's a lot of confusion around medical policies, what's going to be covered. And so not only are we a new business breaking into health industry, but we're also in genomics, which is pretty niche and small, comparatively to the health industry. I have a very kind of unique perspective in that we're kind of removed, but we're right in it as far as we offer a test that can help the clinical care of a patient. It's very important. We really believe in this, but how do we get it out into the market, and then how do we get reimbursed for that, which is a completely different beast, especially when the patient's the one that ends up with the final bill, and yet the physician's the one that we need to convince to order it for the patient. I think we'll talk about the things, the strategy in a little bit, but I think one of the main problems that we've experienced is patient education, and even physician education around how the system works, even what a deductible is, what is a coinsurance, and we've had to shift a lot of our resources towards, okay, we've removed a lot of invoice disputes where patients aren't getting surprise bills, but we've moved it ahead of the curve beforehand, and now we really are under the gun for patient education, explaining to patients what is a deductible, what is coinsurance, what is your correct financial decision here before the testing, and there's a big onus, and it's difficult being a laboratory who's not a direct, who's not really has a direct relationship with the patient. So I think we'll talk a little bit more about strategy in a minute.
Thank you, Ellen. So I think we've started to uncover a bit, touch upon the different dimensions, and I think in some ways as we sort of think about, well, it seems like moving to transparency is kind of, we don't have to poll to figure out, does it sound like something that people are asking for on the consumer side? We've talked about a number of elements. Let's sort of kind of zoom into the business, and in particular, what really makes this hard? And I really liked how, David, not to put your book in the middle of this as a second, but
go right ahead.
But you open a particular chapter. It's the customer, stupid. A little reference to some politics as well there. And with a quote from Bezos, right? We see our customers as invited guests to a party, and we're the hosts. It's our job every day to make every important aspect of the customer's experience a little bit better. And that framing says a lot to me, right? Because it talks about how they think of their relationship to the customer, the fact that it's described culturally and strategically as an imperative. And beyond the veneer of the PR within healthcare, no one's ever. I never met a company that wasn't innovative. Never met a company that didn't say that they weren't customer friendly. But what's underneath? Is this a strategic imperative? What are the aspects of the business that touch upon this that potentially are making this hard? Because it seems like we should just become transparent tomorrow. Is it being prioritized, and what blocks it?
You want me to start? Well, I was struck by Ellen's observation that the client and the customer were two different people. I think healthcare is the strangest business in the world. It's the only one I know of where participants execute transactions without customers. Think about it. You go to the doctor tells you what to do, you do it, doctor gets paid by somebody else. There isn't the direct connection that John just referred to, that Bezos talks about, of actually having to engage with the customer, meet their expectations continuously, and so on. And American consumers are value-driven machines. I mean, everybody decries the loss of the mom-and-pop department store, but they went to Walmart because it offered greater selection, lower prices, more convenience. Walmart's running for its life right now because Amazon is doing exactly the same thing in different ways, taking advantage of the internet. So we have this very bizarre dynamic where the people actually receiving the service aren't engaged in the negotiation for the price. And the other side of that is the way we pay for things is this activity-based payment that I referenced before. So Upton Sinclair, who wrote The Jungle, the one that sort of revealed all the bad things that were happening in the meatpacking industry in the 20s. Great book if you want to throw up several times. But he had this great quote where he said, it's really hard to get somebody to understand something when they're paid not to understand it. So fundamental in the dysfunction in the system is this disconnect between customer and supplier, and the fact that when they get paid for things, they get paid by a third party that's often encouraging them to do things the clients may not want, might not be in their best interest, and so on. So when we were talking earlier, I gave Ellen a bit of free advice, which is if I were in her shoes, I'd be trying to figure out how to get consumers to demand the test, because supply-driven demand has superhero results. McDonald's isn't exploring kale salads because they don't want to sell more burgers, right? They're doing it because their marketplace is changing, they're listening to customers, and they're moving in that direction. Healthcare, first of all, they don't even like the word customer, you use it and people bristle, but that's what needs to happen. And the consumer-driven change and this bottom-up evolutionary way in which Americans drive value, make selections, so on, is ultimately it's going to win the game, and the money flowing into these new companies, new business models are what's going to fuel the change.
And when we mentioned, and maybe it's a good one, Ellen in particular, as I was thinking of your patient choices, how it comes in, where surgery centers will often remark that there is a timing issue, right? They're not exactly getting most of their business at the beginning of the year for those that are sort of waiting for that magic quarter where, oh, their deductibles have been met, and they'll actually see a surge, almost so that they can almost not keep up with their demand in later quarters. So it seems like as you get down to the ground level of patients, which they're not just necessarily showing someone pays. In this scenario, there's a perception related to their share in it, that this certainly is a part of this problem. And I think you were talking about it from another lens.
Yeah, I mean, there's definitely an issue where as a patient, you have no idea how much it costs until you get the invoice, and this tends to be a large problem throughout the industry. One of the things that we've done to try and combat that is we've built a cost estimator. It essentially reaches out to the patient's insurance, grabs their insurance information. It uses historical data from that insurance, that payer, that employer group to try and create a cost estimate for that patient prior to them actually testing. And this is important because it allows the patient the choice: do I want to go through insurance? Should I just pay without insurance for this test? Especially important in optional tests, which in the genomics industry, a lot of times our tests are not regarded as required, they're optional. And when you have an optional test, pricing comes to the forefront of your product as it's a race to the bottom. Who can offer this optional test for the least amount of money? That's the most important to your end consumer. And so that becomes a big juggle. So we created this cost estimator. Like I said before, it allowed us to reach out to patients. We started seeing a lot fewer invoice disputes. Patients really liked the feature. However, we then moved a lot of the overhead to prior to testing. Now we don't even have a test in the door, and we're having to handle a lot of patient education. What is deductible? What does this estimate mean? What is a prior authorization? All of these things up front, which is also difficult because we don't even have a test necessarily in the door yet that we can bill for. So there's a lot of business, there's kind of a lot of business complications around really trying to be transparent in an industry that's so difficult to understand, and then being able to still get paid enough to be able to handle that type of business structure.
And as you look at scale and being a provider, I think you got to involved with a lot of moving parts here.
Thinking about this from the chair I have sat in 3 or 4 different organizations, and looking at it short-term and long-term, we too have done implemented the tool, the price estimator thing, where at least we have begun to nick at the problem of price transparency by allowing patients to get online, use a web tool, enter their information, and figure out how much is this going to cost me if I come to your hospital. What is going to be my out-of-pocket? But I think that's a short-term, small component of where we need to go. I think that I live with the belief that if we can produce share price information on thousands of companies every second, that we should be able to provide price lists of every treatment and every procedure, for the most part, across different providers every place in the country. I mean, look at what Jonathan just talked about. I mean, there's an incredible amount of information out there. We have the technology. It's just a matter of putting it and pulling it together. So when I think about our responsibilities as providers and health systems that are primarily delivering care, I think we first and foremost have to admire the problem, embrace it, and say we need to be part of the solution, which means we got to be part of delivering on the price information, delivering on those dimensions of quality that are important to patients and consumers, tell them what it is, find out, first of all, what it is that's important to them when they think about quality, and pulling that together and delivering on it. I think we, secondly, have to, and we began to do this at our organization, prepare a financial model around the prospect of pricing becoming more transparent and having its market clearing or market efficiency impacts on us. So for example, we looked at our top lab procedures by volume. You know, comprehensive metabolic panel, lipid panel, PSA, whatever those were. And we said, let's take those 5 and let's imagine we price it at Quest diagnostic rates, just for outpatient. And our revenue impact was $5 million, pricing at market competitive rates. So, which gets us to the third element. All right, what's our price strategy? We really don't have one in healthcare. It's an evolution of charges and negotiations over the last 51 years, yep. Okay, because Medicare doesn't pay full cost, Medicaid's even worse, and we have to cost shift to commercial, and therefore you and me and him and Ellen to pay for all of this. But we don't have a price strategy. In other words, we don't look at things like, okay, this is a commodity. Those lab tests, we may have to price lower than our current charge structure and pricing is in order to not lose volume, or make a decision, we're not going to change our prices, we'll take a flyer on what the impact on volume might be. But we have to at least try to estimate the impact of it. And imagine the impact of 5 lab tests, just the outpatient stuff, $5 million of revenue. That's 10% of our operating margin. After building a price strategy, I think we have to, again, think about the dimensions of quality, because we all shop for something on Amazon, at the store, whatever, a service, we're thinking about value, right? What is value? To me, it's quality divided by price. There's only so much price you'll pay for so much quality. Mechanically, we go through that mental gyration as we shop for a TV, a computer, or whatever. We do. There's a price point at which you say, I don't care how good it is, that's too much money.
Yeah. Well, first of all, we got too much, right? So hospitals have to close, specialists have to figure out other things to do, and they're not going to give it up by themselves. So I believe the marketplace has to take it away from them. So I'm counting on all of you smart people creating new business models and new companies to really deliver on the promise of better health care at lower prices, delivered more conveniently. So my watchwords, you can distill my message down to 6 words, which are outcomes matter, customers count, value rules. So the companies that are aligned with patients and follow those principles should win. Those that continue to play this game of optimizing revenue and saying one thing and doing something else, you know what, they deserve to die. And so I tell you what, it really pisses me off that there's enough money in the system to amputate a foot for somebody who's got diabetes and no money in the system to manage the diabetes to prevent the amputation. It really pisses me off that somebody goes in for health care, acute treatment, and we treat that, but then we give them an 800 number to go deal with behavioral health issues, mental health issues. It's like going to the auto shop and saying, okay, we'll fix your engine, but you got to go across town to work on the brakes. It's the dumbest thing you can ever imagine. So until companies figure out what they're good at and start to differentiate in ways that, again, deliver outcomes, meet customer needs, and deliver value, and then, I just don't have any patience for them.